I hope we can start now. Others will be joining soon.
Okay.
Sir, it's not clear, sir, what you're saying.
Okay.
Can
Okay. Yeah, we can start.
Sir, can you speak a little louder?
Can you hear me now?
It's better now.
Am I audible now?
Yeah. Now, can you remove the headset and use only the microphone? Is it possible?
I cannot hear you then.
Yeah. Now it's good. So I think you have to keep the microphone towards your mouth.
Yeah. Okay.
Okay.
So agenda for today's session will be like we can start with sir's presentation. It will extend up to 40 to 45 minutes, followed by a brief discussion on it. By 4 o'clock, we can start our case presentation and its discussion. So we can wind up our session by 4:30.
So today's session is on breathlessness, and it is one of the important symptom in palliative care, not only in patients with lung cancer, but also in patients with many other malignancies. So today's session is by Dr. PANKAJ, who is the Assistant Professor of Palliative Medicine at KMC Manipal. Dr. PANKAJ, welcome, and you can start now.
Thank you so much, sir. Good afternoon, everyone. So today we will be talking about respiratory symptoms. What all are the respiratory symptoms, mainly in cancers and other non-oncological illnesses. Can I share my screen here?
Should I share?
1 second. Sir. Yeah. Can you see my screen now? No?
Yes, sir.
Yeah. Okay. Yeah. So, what are the common respiratory symptoms? Are breathlessness, cough. We'll talk a bit about hemoptysis and respiratory secretions. So, mainly we will talk about the breathlessness in detail. A brief about cough and hemoptysis, and how to manage respiratory secretions. So these are very common symptoms in respiratory diseases, very common in lung cancers or those who has metastasis to the lungs. In COPD, especially in the end stage COPD and end stage heart failure. In patients with severe pulmonary artery hypertension, those with interstitial lung diseases, and occupational diseases. Nowadays, a lot of patients come with occupational lung diseases like silicosis, pneumoconiosis, and those with motor neuron diseases, dementia. So how do we define dyspnea? Dyspnea, also very commonly known as breathing difficulty or breathlessness. So it is a subjective experience of breathing discomfort that consists of qualitatively distinct sensation, and that can vary in intensity. So how patient feel the dyspnea? So there is a pathophysiology. There are some receptors, mechanoreceptors. There are some chemoreceptors, and they feel the senses from our airways, upper airways, the smaller airways, and from the lung parenchyma. So usually what patient complains, and that we will discuss in the assessment also, the quality of breathlessness. So there may be some kind of air hunger or chest tightness or increased work of breathing. So what happens when there's any pathology on the lung or upper airways or smaller airways? These mechanoreceptors and chemoreceptors, especially in the carotid, and they send the afferent sensation to the brain. In the sensory brain, and the efferent signals through the vagus, it can activate the upper airway or chest wall. So there's basically there is a ventilatory mismatch, and there's increased ventilatory demand. There's impairment of mechanical ventilation, and patient usually have to breathe more, and that's caused perception of breathlessness. So this is the prevalence of dyspnea. Mostly you can see those cancers. It may be primarily lung cancer, or maybe metastasis to the lungs, or mediastinal lymph nodes or pleura. Causes a lot of dyspnea to the lung patients. In other patients, especially those with lung diseases like as COPD, asthma, it is 90 to 90%. Again, with heart failure, especially the right-sided heart failure or ISDs, they feel it's a very common symptoms in those patients. In patients with MNDs, because they have chest muscles weakness, the dyspnea is very common symptoms. And in patients with dementia, because they are more prone for aspiration, more for pneumonia, they feel breathlessness is very common in those patients. So how do we assess breathlessness? So assessing breathlessness is very important to manage patients qualitatively. We usually assess in 4 headings. So what's the quality of breathlessness, how the patient feels, then and then impact, what's the distress, and what's the symptom intensity for the patients. Okay, so quality usually, as I said, that either patient may have air hunger. They feel that the inspiration is not sufficient for them, and they need to have more air for that. Sometimes they feel that work or effort they have to breathe is increased, and sometimes that there's a feeling of chest tightness. So these are the qualities of breathlessness. How breathlessness impact for a patient? Many a times, because a patient is breathless, they feel that our disease has progressed, or it's not a very good prognosis. So it implies a negative prognosis for the patient. And they very commonly get anxious by the breathlessness, so that psychological distress associated. And this anxiety or distress can further lead to more breathlessness. Then there are social distress also, because they cannot move out of the home, or if they have to move out, they may need some supplemental oxygen, or when they are going out, they become very breathless. So there are social distress to those patients, and it's very difficult for them to do minimal activities of daily living, and thus it causes the functional limitations for those patients. Then there's maybe a distress. So to see the distress of a patient, we commonly use the cancer dyspnea scale, how much distress they had because of breathlessness. It's a kind of what's the unpleasantness for them. Then to assess the symptom intensity of burden, maybe we can see for quality of life, how it is impairing the quality of life. Very commonly, we use the modified medical research council and dyspnea scale. So MMRC, that is very commonly used. In breathlessness, because of lung origin, we use MMRC, and while those having because of heart origin, we commonly use NYHA. So in palliative care settings, this MMRC is very useful. So how do we grade breathlessness according to MMRC? So 0, there is no breathlessness. It is not troubled by the dyspnea. They can do the exercise, normal exercise. Grade 1 is when they are hurrying or walking uphill, that time they feel breathlessness. Grade 2, they have means on walking at the level or walking along with the people of same age, they have to stop in between or they feel breathless. Grade 3 and grade 4, that is severe dyspnea. So when grade 3, they cannot move out of more than 100 yards, and they have to stop in between because of breathlessness. And grade 4, that is very severe dyspnea, and they cannot even come out of their home because of this. So what are the common causes for breathlessness? I thought we will discuss it, but most of you are not sharing screen. So yeah, I will only talk about it. So what are the common causes of breathlessness that you see in your patients? I see here mostly those with lung cancers. They have quite a lot of breathlessness. It can be because of complications or because of cancer only. Other means they can have pleural effusion, they can have super added infection. Sometimes there are too much of secretions and that causes breathlessness. So whatever the cause, we have to treat it. We have to find out the cause, because our treatment will be based on that thing. So in any setting, whether it's a palliative care setting or the curative setting, we have to find the cause and treat for the cause. So then management of dyspnea. So management of dyspnea, as with other symptoms, we manage the pain, the physical management of pain, and according to that, there's a very important role for the rehabilitation. So first is rehabilitation model. So this is the approach of dyspnea. It has been divided into four component. So first and foremost is the minimizing the production of symptoms, so that they should not have symptoms at all. Second is to reduce the impact of symptom. Third is to diminish the perception, and fourth is to modify the impact of whatever the symptom is. So to minimize the production of dyspnea, so they should not have dyspnea at first point. We can give supplemental oxygen. Oxygen is recommended in dyspnea management in those who have hypoxia, basically saturation less than 88 or PaO2 less than 55. So that is to minimize the production of the symptom. There are some breathing techniques that we will discuss so that they do not feel dyspnea at all. Adequate nutrition, especially in the patients with COPD and MND, is important because they have an increased work of breathing, and because of decreased nutrition, the breathlessness, they feel more breathless. Their work of respiration decreases. So providing good nutrition is also important in those patients. Then how can we reduce the impact of symptoms? They have a symptom, but how can we reduce it? So like this, if you have attended a fatigue, you have read about fatigue, it's the same for the dyspnea. So they should have some energy conservation techniques, so they can do those activities or whatever they are important, or they can prioritize the activity that is important for them when they are not breathless. So that is one energy conservation and activity method. They should try to minimize the activities which causes breathlessness more. There are some posture, like if on the propped up position or in sitting position they feel less breathless, that posture or ergonomics at the home or hospital or hospice can be modified according to that. There are some lifestyle modifications, like they shouldn't, if they are breathless on walking, maybe MMRC grade 3, they can use a wheelchair and do as less walking as possible. And they should have is what if they get exacerbation of breathlessness at any point of time, so there should be action plan for everything, like if they want to go outside for travel or something, do they have oxygen facility during travel or their stay, like that. So this is a rehab model. Then the palliative model that includes two domains, like diminishing the perception and modify the impact of uh, model. So there are some pharmacotherapy that we will discuss, like opioids, what's the role of opioids, what's the role of bronchodilators, and how anxiolytics can help. There are a lot of non-pharmacological and very important non-pharmacological management of dyspnea. And the psychological, how the psychological distress we can address, or we can counsel them for the breathlessness, it can decrease. And there are some complementary and alternate methods for dyspnea management. Okay, so this is like for pain, there is some step ladder for dyspnea management. It has been devised for severe COPD, but it can be used for breathlessness of other causes also. So first and foremost is to optimize bronchodilators. It may be short acting or long acting. There may be some exercise training, supplemental oxygen if required. It is the step one. If dyspnea persists or it is increasing, then we can use some non-pharmacological measures like pulmonary rehabilitation, post-lip breathing, role of fan. There are some relaxation techniques and paced activities. And if nothing works, then the palliative pharmacological measures like morphine, dose titration, and anxiolytics. So in thorax, this journal, there was a full supplement for breathlessness, and this means palliative care in COPD and other lung diseases. So that for further reading, you can read that supplement. So first we will discuss about opioids. So when I talk about opioid for breathlessness, most of physicians raises their eyes like how opioids can be used. But I hope you may be knowing that opioids are very mainstay of breathlessness management if it is in, refractory to other treatment. Bronchodilators are very commonly used, or I will say like almost for all patients it is used with breathlessness, and anxiolytics whenever needed. So how opioid can reduce the dyspnea? So many a times this breathlessness is associated with the pain, and if we reduce the pain, and the breathlessness also comes down. So when there is a reduction in pain that is induced by the increased respiratory drive, it can decrease the breathlessness. As you know that maybe for MI we use morphine as a part of MONA, and what we learned during our MBBS days, like morphine decreases the anxiety, and it can decrease the breathlessness by that way. It causes the vasodilatation, so it decreases the preload to the heart, and that's also in IHD, acute angina, or MI. It is used for breathlessness. And there are more sensory mechanisms that is very important for the morphine to act. Like it causes the respiratory awareness, so that patient will not feel the impact of breathing. Am I audible? Because my screen is showing.
Yes, sir, you are.
Yeah. Okay. So There, the cortical sedation, what it causes, that means it blunts the respiratory awareness, what we discussed during the afferent. There are afferent signals the pulmonary pulmonaries, or there maybe from small airways. Nowadays, there are some trials to use inhaled opioids. So inhaled opioids are used that blunts the neurotransmitters, that is means through the afferent transmissions of pulmonary mechanoreceptors. So they will not have the systemic toxicity of morphine or other opioids, and it will blunt the afferent sensations only. Other mechanisms are alteration of the neurotransmission within the medullary respiratory center, and as you know that hypercarbia, that's increased CO2 or decreased oxygen, causes that chemoreceptors to activate, and so it decreases that sensitivity also. So these are the few mechanisms by which opioids are thought to be used for dyspnea. So nowadays it has been recommended as grade A recommendation for patients with advanced terminal diseases and refractory dyspnea in those patients. This is from Indian Journal of Palliative Care. So this is the list of inhaled bronchodilators that are used to decrease the perception of breathlessness. It should be mainly used in if there are wheezes or there is bronchoconstrictions. But in COPD, you should regularly use the long-acting bronchodilators, and according to the gold criteria, you can add anticholinergics or inhaled glucocorticoids as needed. If time permits, we can discuss a bit of COPD also, on the palliative care in COPD. Yeah. So these are some medical measures what we use to manage the dyspnea in palliative care setting. So oxygen, as I said, that it can be used in hypoxia condition. It has not been recommended in those patients who has saturation more than 88. In those patients, maybe in just room air or flow of air can be advised. Or sometimes there is some medical air they have tried that can be used. So how oxygen works? It improves the saturation. It causes the placebo effect because that cool air moving to the face, and there are mechanoreceptors on the face. There are mechanoreceptors on the face. There are mechanoreceptors on the chest, at the nose. Mucosa of nose has mechanoreceptors. So when these oxygen blows through the nasal bronch into the face or in the nose, it causes the cool and that effect. So very common medical symbolism, like any patient, if he is breathless, the nurses put a venturi mask or nasal pranks to the patient. So it's a medical symbolism for the management of dyspnea, and that decreases maybe the perception of anxiety or dyspnea. It also stimulates the second branch of trigeminal nerve and inhibits it centrally also. Then some anxiolytics like benzodiazepines have been used more in the refractory settings, or when there is breathlessness associated with the anxieties. So midazolam or lorazepam or clonazepam can be used. Bronchodilators, if there is any bronchoconstriction or airway obstruction is there, it can be used either as a oral or nebulized form. Diuretics like furosemide is very commonly used if there is any pulmonary congestion is there, or sometimes in patients with SVC obstruction, or if there is a lot of pulmonary secretions, furosemide can be used. Steroids are very commonly used drug. It is used in very high dose in airway obstructions, maybe because of compressive lesions, if there is a small or large airway obstruction, or it is because of SVCO, superior vena cava obstruction. It can be used. It can also be used in lymphangitis carcinomatosis, and that is when all the lymphatic channels in the thorax have been affected by the cancer, and cancer has spread into it. It causes a lot of breathlessness. So the steroids can work in that. And in COPD or bronchoasthma, very commonly prednisolone or methylprednisolone can be used. Sometimes anticholinergics are used to decrease the respiratory secretion if it is causing more of breathlessness. Sometimes, especially in COPD patients or those who are on BiPAP, sometimes a temporarily non-invasive ventilation can be used, but again, it should be used if patients feel it is more beneficial for them, or they have temporarily it can be used. So that ethical dilemmas are there with the use of NIV. So it should be discussed during the goal of care conversations for the patients, whether they want NIV or not. Then these are some of non-pharmacological management of breathlessness. First and foremost is the fan. It is very commonly used and very effective way of managing the dyspnea. So if the patient is breathless and he is not hypoxemic, we can advise to keep a table fan near the face or a handheld fan near the face. Now that gush of air activates the mechanoreceptors in the nasal cavity or at the face, and it thoughts means that maybe the mechanism, and it decreases in the dyspnea. So at home, if the patient is at home, this techniques can be used if they don't have the oxygen at home. This is the very effective management, and it has found to be effective in many of the studies. So very of the few methods that has been shown beneficial by the evidence. Then some relaxation techniques like progressive muscle relaxation or guided imaging can be used. Can I extend a bit? I think it's 3:35. So 3:50, can I extend a bit?
You can take 10 minutes more.
Oh, yeah, okay. So some of other relaxation techniques like counseling or music therapies can be used. Breathing technique is very important, especially in COPD patients. So those physiotherapies and breathing techniques are very helpful. Chest wall vibration and neuromuscular electric stimulation, that has been shown benefit in many of the MNDs patients. That has been regularly recommended for them. So these are some of the evidences of what works, and according to evidence what works and what doesn't. So like in hypoxemia, oxygen works. On the pharmacological, oral and parenteral has found to be effective. In opioids, mainly the morphine, and sometimes fentanyl also can be used. Here fentanyl, I mean to say the IV fentanyl or buccal lozenges. Psychotropic drugs like anxiolytics, in some evidence it shows, but some evidence doesn't show any benefit. Non-pharmacological, especially that breathing techniques, the fan and rehabilitation has a good evidence for the non-pharmacological treatment. And if the breathlessness is refractory, it is not able to manage by any other technique, then last resort is palliative sedation. So it is to relieve the suffering because of refractory symptom, and for that we, with that intent, we induce state of unconsciousness or decreased consciousness. So it is very commonly used for delirium or pain, but for dyspnea also it can be used in the terminal stage. But before that, we should very uh, uh, effectively we should communicate with the family members. We should take their informed consent, and we have to document what's our intent by doing the palliative sedation. I think I will skip COPD right now. If time permits, we can discuss about that. Then is the cough. So cough, again, it's a very common symptoms in patients with cancer, with lung cancer or metastasis, and in other patients also, like dementia, MND patients. It's a very common symptoms in them. So pathophysiology, this can be a pulmonary cause or extra pulmonary cause. It's within the lung, or some like a heart or esophagus. It can cause cough. So usually there are some inflammatory mediators or damage to the epithelium of the airways or the lungs that causes the afferent sensation into the afferent nerves of airways, and through that it can through the vagus it can go up to the higher cortex. Sometimes esophagus, especially the GERD or the reflux, can irritate, and same is for the heart. If there is any pleural effusion, cardiomyopathy, that these can cause cough also. These are a few causes. I will not go in detail of them, but these are the few causes that can cause the cough. So what are the treatments? So as for other symptoms, correct the correctable things, whatever causing the cough. If there is any pleural effusion, we have to remove the pleural effusion. If there is any infection, tuberculosis, anything, that things has to be given. There are some palliative measures like environmental modifications. So some humidifier air can decrease the symptom of dry cough. Sometimes supplemental oxygen, if it is because of hypoxemia, the airways are getting irritated, and then supplementary oxygen helps. We should avoid the airway irritants like smoke, and proper positioning, maybe in the sitting position if they feel better. Those positioning should be given, or the lateral position for the lying down position. Antimicrobial use, like antibiotics, should be very carefully used. Uh, we should not start empirically to all the patients, but if it is needed, if there is any symptoms of infections, we should use antibiotics also. The antitussives, what we use, antitussives are usually used to decrease the cough reflex. So first, we should not use antitussive in all the patients. In those patients, especially the dry cough, or in those in refractory cough, we can use antitussives. So it can be centrally acting or peripherally acting. Centrally acting, they work at the opioid receptor in CNS, and they suppresses the cough reflexes. Peripherally acting, they acts on the sensory afferents. So commonly used peripheral acting, one is benzoate or chromogaicate. And this decreases the sensory afferents from the lungs. Very commonly used centrally acting opioids are codeine, morphine, and dextromethorphan. So these can be used. Codeine is converted into morphine in the liver, and then it decreases the cough. Some studies says that tramadol and tapentadol has the same efficacy, antitussive efficacy as codeine also. So these things can also be used, but codeine has been very commonly used as antitussives, and where codeine and morphine is not available, dextromethorphan either in the lozenges or syrups can be used. Uh, then the steroids, as I said, for the dyspnea, same way it can be helpful in the cough also. So in airway obstruction, if there is external airway obstruction, it can reduces the edema around the tumor. It can help in lymphangitis carcinomatosis, especially in the oral IV or inhaled steroids also. And if the patient is on radiotherapy to the thorax or chemotherapy, if it is causing the pneumonitis, it can decreases the cough because of pneumonitis. Many of the times patients are not able to cough the sputum, or sometimes it is very thick. So the mucolytics substances can be used. The commonly used one is the normal saline nebulizations. Guaifenesin and acetylcysteine, that is mucomix, can be used as orally or through the nebulizations. Guaifenesin and Abraxils are available as syrups, so that can be used as a mucolytics or cough expectorants. So idea usually what is practiced, like for the productive cough, we use the expectorant until unless it is very severe and patient is terminally ill. And in the dry cough, mostly the antitussives are used. Then comes the respiratory secretions. So respiratory secretions, it's because of the excessive airway secretions. It can cause noisy breathing. It can cause the cough or breathlessness. So for respiratory secretions, like there are some airway clearance therapies like autogenic drainage, like the patient itself like to drain the secrete, or there may be some forced expiration that causes the actively clearance of the airway. Some passive techniques like postural drainage on the other side, on the lateral position, patient can lie down, and there may be some percussion exercises or chest physiotherapies that we can do to induce the excretion of respiratory secretions. It's commonly used in those who are very malnourished or not able to expectorate. Because of respiratory secretions, there are especially during end of life phase, a noisy air comes, so that is called as death rattles, and it is many of them very distressing to the family members. It may not cause discomfort to the patient, but for the family members sometimes it is very distressing. And they have found that it is a very strong predictor of death. So when comes it's a predictor of death also. So that also increases the distress for the family members. So we can use some anticholinergics for that. Commonly used one are the halcyon, butyl bromide, or glycopyrrolate. We can also use the atropine also. Suction usually is not recommended in death rattles because it causes the discomfort for the patient, but sometimes if it is excessive secretion, gentle suction can be used to manage the death rattles. Then we will talk about the hemoptysis. Hemoptysis can be because of many causes. Again, in cancer, it is maybe because of the lung cancer or metastasis to the lungs. Or maybe sometimes because of coagulopathy, it can be, there may be some infection that can occur. We have to assess what's the cause of hemoptysis. We have to treat whatever the cause is. In brief, I will just discuss about the management. So management depends how severe is the bleeding, what's the quantity of the bleeding, how urgent is it, and what's the patient's condition at that point of time. So if time permits, or if we can correct the correctable cause, we have to treat that with the antibiotics, ATT if needed. If there is in the patients with cirrhosis or liver failure, if there is coagulopathy, or if there is thrombocytopenia, correction of the platelet, those all things we should do. Sometimes we can use the hemostatic RT to the lung mass or bronchogenic mass that can decreases the radiation. In pharmacological treatment, we commonly use the tranexamic acid. It can be given orally or IV. Sometimes we can do the bronchoscopy and give some cold saline lavage, or we can give epinephrine locally, or we can give locally tranexamic acid also. If a patient is in the terminal condition, or the bleeding is profuse, there is terminal bleeding, and we recommend to have some emergency kit for that. That consists of dark towels that the family members can keep at the mouth, so that they don't have the fear of the blood by the sight of blood. They can use some midazolam, so they can put it orally and the patient can go into the sleep. This is for the very large hemoptysis or severe hemoptysis, or the patient is in the distress. Sometimes if there's a localized cause, we can get the surgeon's opinion, or we can do the angioembolizations also. I think I will stop here. We have covered most of the symptoms, respiratory symptoms. There are some COPD we cannot cover, but you can have this access to this slides. Okay. So can I have some questions, any doubts about these things?
So Dr. Pankaj, Dr. Pankaj covered a few respiratory symptoms, including breathlessness, cough, death rattle, and one more, hemoptysis. Yeah. So I'm sure you will have many questions on this because you will be seeing many patients having these problems, and you can ask your doubts. Dr. Gaurav.
Hello.
Hello.
Yeah. Good evening. I had actually a few queries.
Yes, sir.
Just ask them one by one. The first being out of the inhalational steroid versus injectable steroid, which is as per our studies, which has been shown to be more effective. Means can we avoid the injectable part?
Yeah, so steroids are very commonly used, especially in COPD. So what the gold recommendation is to use the inhaled glucocorticoids. That's budesonide you can use, or other glucocorticoids you can use. That is the first recommendation. If with that breathlessness doesn't come down, the next step to use the systemic steroids.
So, systemic, any preference for any particular steroid which you should use?
Because if it is a obstructive airway disease like COPD or asthma, they prefer methylprednisolone and prednisolone in lung diseases. If there is any obstructive disease because of the tumor or because there is any edema, SBC obstruction or airway obstruction, evidences are for dexamethasone, IV dexamethasone.
Second thing is regarding the relaxation technique where you said regarding guided imaging. So what is guided imaging?
Guided imaging, it's basically psychotherapy mainly. So they show it's psychological interventions they do, and in that I'm not sure, but they show some images, and through that some relaxation, or sometimes they ask them for the imagination of some situations.
So it will be done by the psychiatrist or psychologist?
Psychologist mainly.
Psychologist. And the third question was, you said that inhalational oxygen only after 88%. So my question was, why 88%? Why not 90% or 85%? Any particular, because you mentioned a particular cutoff.
Because hypoxemia means the definition, by definition it is hypoxemia if saturation is less than 88%, and then we call it hypoxemia. Or other, if we are using the arterial line, then PaO2 less than 55%, and that's the recommendation. They say if it is not hypoxemia, there is no use of oxygen. You can use some other, means normal air or fan you can use. That will have equal efficacy.
That's all.
Yeah, thank you, sir.
Guided imagery is something in which suppose the patient is breathless or have pain. So you will ask him to think of some pleasant situations. Suppose he want to fly. So he is just giving him instructions that you are flying, and when you look downwards, you are seeing many beautiful flowers, rivers. So that is the way they give instructions on guided imagery, and that will give some relaxation. That's what I read about guided imagery.
Okay.
Any other questions?
I think one of the common question that should come forward is the use of opioids in dyspnea. Dr. Pankaj mentioned about morphine in managing breathlessness. So all of us are very much worried about using morphine or other opioids in breathlessness. Don't you have any doubts on that?
So, is anyone is using opioids for breathlessness, or anyone has seen using opioids for breathlessness?
Dr. Anshika?
Sir, thank you for a wonderful presentation. So I have been using low dose morphine regularly for breathlessness in cancer. Am I audible?
Yes, 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 yes.
So I've been using regularly, and I've found that morphine has got very good, gives a good outcome actually in cancer patients with breathlessness. And second thing I found very useful is non-pharmacological methods. As you mentioned, cool wind across the face, loosening of the clothes, and of course relaxation of the patient. So I found both the things very useful. I've been using morphine regularly.
Yeah, and that's what the evidence also says.
So low dose morphine, if there is no pain at all, I use 5 mg.
Mm-hmm.
And if they have pain, then whatever my dose of the pain is, I increase it a bit. That's all I'm using.
Okay. For those, there are a lot of literature. Someone has started with 0.5 mg in COPD, and there are some evidences for sustained release morphine, 20 mg sustained release morphine. So the dose varies. So I will suggest to start with the lowest possible dose. maybe 2.5 mg because we have only 10 mg morphine. So in the minimum we can divide it into 2.5. So we use 2.5 mg 4 times in a day we can start with, and later we can increase.
So Pankaj, do you use morphine 4 hourly or even less frequently than the usual schedule?
Usually we do not use 4th-hourly. We use either thrice a day or 4 times a day for breathlessness. For pain, we use 4th-hourly. For breathlessness, they says for sustained release once a day or twice a day. For intermittent immediate release, maybe 4 times in a day we can use.
So is there a difference between the use of opioids for breathlessness in malignancy and COPD? Is it the same or is there any difference?
What I read is a dose of opioids required in lung diseases, the COPD or ILD, is much lesser than the dose required in the cancer settings. So maybe the higher doses are needed in the breathlessness because of cancer. But much lesser doses is required in COPD. So one article says that the starting dose can be as low as 0.5 mg for COPD in COPD. Yeah.
It's a common fear that opioids produces respiratory depression. So what's the evidence for against this respiratory depression?
Respiratory depression, first of all, means if we use opioid according to the need, that's adequate titration of the opioids, the chances or what we've seen in the studies in the literature is very, very less. It's the same for the pain also. There are very few incidences of respiratory depressions if we have used carefully or titrated accordingly.
Anybody else? Any of you have any more questions?
Dr. Bipin, you wish to speak something?
Yes. Can we use the benzodiazepines also in COPD patients?
In COPD patients, benzodiazepines have been used, but if there is need, mainly if the patient is having anxiety, or if it is a refractory breathlessness not coming down, then we can start with low dose benzodiazepines.
Which one you suggest?
Commonly used one is the clonazepam because it decreases the anxiety. Clonazepam, or if you are using oral, then clonazepam. If we are using IV, then midazolam is the recommended because it's a shorter acting.
How is the dose of midazolam?
1 mg.
What is the role of haloperidol in these patients?
Haloperidol, I haven't read about haloperidol in breathlessness. There's been some SSRIs has been used for breathlessness, but the evidence is very low, and it is not a common practice to use haloperidol for breathlessness. It can be used for sedation, but for breathlessness, it is not commonly used. There are some role for prothiazine in breathlessness, but again, the evidence doesn't support much.
Thank
you. Okay.
So we discussed about breathlessness, which is a very common symptom, not only in malignancies but also in other non-malignant conditions requiring palliative care. Breathlessness pathophysiology, it's complex, but it is the mismatch between afferent and efferent signals. So if there is a mismatch, that will be perceived as breathlessness, and it can be influenced by many other factors. And the quality of breathlessness, it differs from person to person. There are many causes for breathlessness in malignancy or in any other patients. So we have to look for the correctable causes, and along with the correctable causes, you have to start the non-pharmacological management as well as the pharmacological management. So you have seen the step ladder for managing breathlessness. Um, and how many of you have seen death rattle? Dr. Pankaj was speaking about death rattle. How many of you have seen? Can you raise your hands? Okay, Dr. Anshika. Uh, okay, thank you. So, death rattle is a very common symptom and which occurs in about more than two-thirds of patients who are going to die within 48 hours uh, or 72 hours. Mostly the patient will be unconscious during this death rattle, and it is the concern of the caregivers that this patient is making some sounds. So it's our primary management will be to give some comfort for the caregivers, console them that this will not this is not choking, and the patient will not be aware of the situation because he is unconscious, and you can posturally drain the secretions, and if not getting relief, then you can use other anticholinergic medications like glycopyrrolate, hyosin bromide, or even atropine eye drops can be used. And hemoptysis, the causes might be variable, and you have to manage it considering the patient's disease condition. So we shall move on to the patient story. Dr. Suraj Kumar will be presenting the patient story. Dr. Suraj?
Yes. Yes, sir. Am I audible?
Yeah, you are audible.
Okay. Good afternoon, all participants. I am Dr. Suraj Kumar Gohil, working as a tutor at Radiation Oncology Department, Government Medical College, Vadodara, Gujarat. Next slide, please. Today I am presenting a case of a female, 65-year-old, who is a case of cancer of left lateral margin of tongue, T4A, N2B, MX, stage 4A. Histology was squamous cell carcinoma. Next slide. Presenting complaint. Patient is having non-healing ulcer over tongue for last 6 to 8 months. Patient is having pain at local site, that is tongue, for last 1 month. Patient is unable to eat for last 15 days. Patient is unable to speak for last 15 days. Patient is having swelling on neck for last 15 days. Next slide, please. History of illness. Patient was diagnosed with the disease in November 2018, and patient was attended by ENT department and advised surgery as it was operable at that time. Patient did not want surgery, so she left and went to other hospitals. Same advice was given by other hospitals, so patient did not take any active treatment or any medication till now. Now patient referred at our department for further management. Next, examination. On examination, there was an ulceroproliferative growth over left lateral margin of tongue, which is 5 into 4 centimeter with slough over it. It is involving floor of mouth. Tongue is fixed. Neck swelling over left side, which was 2 into 2 centimeter, hard, fixed, and non-tender. Right side, there is no swelling palpable clinically. So this become a clinically T4A and 2B MX. Foul smelling was coming from mouth, and the pain score was 7 out of 10 on numerical rating scale. Other vitals are normal. Treatment and significant investigations. When patient was examined first time, CT scan was advised and biopsy was taken at that time. CT scan was showing 13 into 12 side heterogeneously enhancing soft tissue lesion involving left lateral border of anterior two-third of tongue, few nodes of sub-centimeter sized at level 1A, bilateral 1B and 2. Patient advised surgery and explained side effects of surgery. Patient was afraid of side effects and she went and did not take any treatment for next 2-3 months. And then again patient went to other hospital. They also again get done CT scan. CT scan was showing 4 into 2.5 into 1.8 centimeter size. This was in February 2018. This size was increased and the site was same, that is left lateral margin of anterior two-third of tongue, and there is no obvious contralateral extension also. And few sub-centimeter size non-necrotic lymph nodes, bilateral level 2 and left cervical level 3 nodes were seen. Again, this was operable by ENT surgeon, so they advised surgery. And again, patient left that hospital without taking any treatment. So no any active treatment taken until now. Other investigations, CBC, RFT, LFT within normal limits. Family history. Patient has 4 children, 3 female and 1 male. All are married and they have separate families. Patient is staying with her daughter-in-law who has 2 children, 7-year-old boy and 2-year-old girl. Husband of the patient expired in 2010. So the primary caregiver becomes the daughter-in-law. Patient is a housewife. Her social support is good. All members are well connected to family. Financial condition is average. Her son is the only earning member in the family and earns around 8,000 per month. Patient is aware of the disease from the beginning but avoided surgery because of complications. Patient was told that she will not be able to speak after surgery and her face will be distorted. So patient is not willing for the surgery. The main reason for not going for surgery is that she will not able to speak after the surgery and her face will be not as she looks like. So she avoided the surgery. Next slide, please. Patient relatives were ready for surgery, but patient is not, was not willing. So uh, earlier, patient was explained about the outcome of the disease and counseled for the disease also. But because of her belief and ignorance, she did not get any treatment. Now patient is in guilt. Now she is not able to speak, not able to swallow. Her face is also distorted due to disease. So before the surgery, she was good, but after this time of after this some time, she becomes palliative patient. So there is okay. Next, financial support. Patient is not having any external financial support. Next slide, please. Now at our department, we have planned a palliative weekly RT over the deceased side. And for 7 days, and tablet morphine 10 mg SOS for breakthrough pain, tablet paracetamol 500 mg TDS for 7 days, tablet famotidine 20 mg BD for 7 days, tablet bisacodyl 5 mg HS for 7 days, and syrup cremafin 30 ml HS, tablet metronidazole 400 mg TDS for 5 days. Patient told to come back 2 days if pain did not relieve with this medication. Next slide, please. This lady was summary. This lady was initially curable case with stage 1 disease. Because of her negligence towards disease and beliefs, she became palliative patient. Maybe this is the case of bad communication between the doctor and patient at the time of diagnosis, or negligence toward the disease by the patient. Next slide, please. Main concern Patient's main concern was about the cure of the disease, whether she will be healed or not, pain will be relieved or not. These were the main concern of the patient. Next slide, please. Discussion points. How to overcome the beliefs of the patients. What else can be done in this case? Some patients have more faith in their relatives and neighbors than the doctors. How to overcome this type of patient? And when patient was diagnosed, if she was not aware about the outcome of the surgery, that is side effects, she might be undergone surgery and may be cured. So is it true that some outcomes of treatment should be discussed with relatives only and not with the patient? So my concern. What can be done? Thank you.
Thank you, Dr. Suraj. So I think many of you have faced the same situation, and I would like to know how you managed or how you are managing this type of patients. Yes, Dr. Anshika.
Working in the North India, I'm in Dehradun, Uttarakhand. So we are very much near the UP and Bihar, all this belt. So there is a lot of head and neck cancer here because of oral tobacco and supari and all this usage. So this scenario which you have put up is one of the commonest scenario where the patient has been advised curative treatment, and because of the probable poor cosmetic outcomes and fears, and the neighbor may have said something, the relative may have said something, they won't even want to have the biopsy. So this is a very common scenario. So we know that we can do only when we have seen the patient at this time, what we should do, what best we can do for that patient, rather than contemplating on what they could have done before. This is how I am managing, or we are managing here. Patients may have some guilt and may not have some of them, but what we can do best for this patient right now, even now I feel if we can try with neoadjuvant chemotherapy because it is CA tongue and it is T4N2. So although you've described the primary, we could give neoadjuvant 2 cycles and reassess. And many of our patients, we are able to do a total glossectomy and put a pectoralis major flap. But then we have to counsel them for a feeding procedure, feeding gastrostomy, and of course that they will not be able to speak well. So the patient has to be on board with this kind of procedure, followed by radiation, adjuvant radiation.
Yes, ma'am. We are also planning the same. We are in many cases. So it is a good, but his patient is a 60 old lady. So that's why we plan palliative. And patient is also coming from far. So
if our aim of treatment is palliative treatment, then with the intention of palliation, then would you consider giving her metronomic chemo only?
Sorry, ma'am, I didn't get.
Only metronomic chemo, because the intent is palliation now.
Sorry, but I don't don't
oral
understand.
Oral capecitabine and celecoxib, which he can take at home.
In some of the cases. Yeah, take it. Hello. Hello, ma'am. Please continue, ma'am. I was not able to listen.
So in our institute, if we have to give something with the palliative intent in a patient like this, so there has to be a reason to give radiation, either hemostatic or pain relief. Otherwise, we are giving metronomic chemo, which is the tablet, capecitabine, celecoxib, combination which they should take at home, and they keep visiting us. And of course, the rest of the palliative care. But the treatment wise, for disease modifying, we are going on with the metronomic chemo.
Thank you, ma'am.
So, Dr. Suraj, you were asking how to overcome the beliefs of the patient. So, can you tell us what exactly was the belief of this patient?
So, patient was thinking like this can be not cured, or what will I do if I'm not able to speak? How will I communicate with others? At that time, when initially she was diagnosed, and she didn't go for surgery because she was having fear, and that's why.
Okay. So, Dr. Gaurav, do you discuss all the problems like complications and how can we manage the problems with patients?
Yeah. This being initially, it was a curable tongue cancer, and now it's become incurable. So what I wanted, means what was going back at the back of my head, was when the surgeon sat her down in the clinic, he definitely did his job of telling her that, look, your face might be distorted and you might lose your ability to speak properly, if at all. What he did not tell her, that if you don't do this, you will die. This he should have told her in practical. Now, because we are not in the habit of telling things in the way they are, now this is the case which now the patient will die. After this many months, now the patient will die. But it will be a very sorry state of affairs for her. So I think on one hand, when we offer a therapy and we discuss all the side effects and all the possible complications and drawbacks, I think we should offer the opposite side also, that if you cannot take any therapy, but the other option is that disease will grow, it will metastasize, and within some months or maybe a year, possibly you will have metastatic disease and you will die. So we should present that scenario too, because cancer will not forgive, it does not forgive anyone. And secondly, what could have also been done is, possibly we could have discussed the cases with all the others, maybe surgeons and maybe medical oncologists and radiation oncologists. Now, this being a T4A disease with N2B, I think even neoadjuvant chemotherapy has failed a lot. We have the experience which we had. Initial results were good, but the patients do come back. We do good surgeries and we give radiation, and then again the patients tend to keep failing again in the tumor bed. So that's a reason to worry. That's why we don't advocate neoadjuvant neoadjuvant chemotherapy in oral cavity cancers nowadays. So the best thing, I think the doctors are doing well. But I had only one question: why is she getting weekly radiotherapy? I can't really understand that. What is? I would like to ask the doctor, what is the dose fractionation you're giving for this patient?
Sir, at our department, we are giving palliative weekly RT for 6 fraction, 6 gray per fraction. That whole becomes 36 gray, and this was intention to reduce the tumor mass. There wasn't bleeding, so it is not an hemostatic radiotherapy. It's for the palliation and for reducing the tumor mass. Yeah, some of the cases we are also giving neoadjuvant, and then we can put them on RT plus CT, not palliative, but the curative one. If patient is not willing for surgery, we can go for our radiation oncologist doctors, our consultants are planning that. So there may be we have some such cases also.
The problem.
In this case, we are they have thought about the reducing the tumor mass.
Yeah, no, that's totally, I understand that. But the problem with neoadjuvant chemotherapy also, considering she's a 60-year-old female, that her tolerance to concurrent chemoradiation, not for this patient, but for other patients, will be very poor. you can't barely give 5 cycles of concurrent chemoradiation. You're giving on a weekly basis. And secondly, I understand that what I wanted to suggest is, if I understand that she's from far off and she can come only once a week, so why don't you try the quad shot? I don't want to go into the details, but it's just a suggestion, because this is not a radiation platform at all. So I think quad shot would have been easier both for yourself and for the patient. So that could help. But neoadjuvant chemotherapy is totally out of the question, especially in this case. So I think you are doing quite a good job. But I thought maybe the radiation needs to be a bit of tweaking, so it would be helpful to the patient and both to the department also.
Thank you. Thank you.
Pankaj, do you have any comments on the first two questions?
Yeah, actually, yeah. So this is can I am I audible? No.
Yes, you are audible.
Okay, yeah. So this is very common scenario what I have seen in Tata Memorial also and here also. So forget the head and neck cancer, it's for the all cancer treatment, because they fear about various toxicities and they don't want treatment, especially the elderly ladies. They don't want treatment. Sometimes they feel that they are burdened by the treatment and they can be burdened on the family members. So what we found that integrating palliative care services in these situations can be very helpful. What we call the early palliative care at the time of diagnosis. So because their anxiety, their distress is quite high at the time of diagnosis, if we integrate those patients in a good communication, good counseling, we can identify their fear, their anxiety, and we can address. So a few weeks ago, just we had one similar case here, and we tried to find out what are the fears. So maybe they are, like those head and neck patients, they have a fear of disfigurement, especially the ladies. We have to very sensitively tackle those situations, and the counseling at that point of time might save the patient. Another thing is what can be done. So I heard that the oncologists are trying to what other oncological treatment can be given. But at this point of time also, she must be in a lot of distress, lot of guilt she is having. So we have to forget about the past and we have to talk about the present, what can be done, and if there is any possibility of giving the curative treatment, and their goals of care is also matching with that the treatment. We should counsel in that way. I think integrating palliative care services, if it is available in those patients, will help a lot. If palliative care services are not available, at least some social workers, psychologists, or at least volunteers, they can help. Many a times the uh, uh, what we call it support group meetings. So the same kind of patients and their family members meet with each other, and they speak, they tell about their stories, especially the success stories. If they tell about the impact is quite better in those conditions. So that few things that could have been done in these patients, or we can do in such patients.
At the start, when this patient had stage 1 disease, the doctor usually discuss about what should be the treatment, and this patient probably denied the treatment because of the disfiguration that can occur, and also the sound production. That's what Dr. Suraj Kumar was telling. So, do you usually also counsel regarding what can be done for this disfigurement and for sound protection? Dr. Anshika?
Sir, the question was, how do we counsel the patient? I didn't get the question.
Yeah, and this patient denied surgery at first. So Dr. Suraj was telling that she was feared of disfigurement, and also he will be unable to speak. And there will be some other reasons which we don't know. But usually, do you give some solution for
Yes.
this, or do you usually explore what are the fears? Why
Yes.
don't they undergo surgery?
So, sir, in this scenario, there are two factors. One is, as Dr. Pankaj also pointed out, she is an old lady widow, and she is being supported by her son and the family. So there are a lot of financial problems she is going to create because of her treatment, is what they think. They are going to be a burden on the family. So when this patient is sitting in my OPD, and I know it is with curative intent, I'm going to operate a simple wide local excision and neck dissection. So, when you're counseling the patient and the relatives, from their body language, you can make out whether they are going to come back and get it operated, or they're having some doubts in their mind. So we usually, when we are taking up a new patient, we do extensive counseling. And in this T1 or T2 lesion also, when we do even if you do a hemiglossectomy for a big lesion, so what all changes are you going to get in your speech and voice? So usually we tell them you can make sound. It is only the words. Some words will be different, and you will not be able to phrase every single word properly, which with adequate training, after a few months, you will be able to get back. Second thing is about chewing and moving around the food, and sometimes swallowing if it is in the posterior tongue. That also we tell them in terms of percentage, that this much difference may be there from now. Even now with the disease, you have the problem. So this much percentage more you may have the disease. And we do extensive counseling. And I think most of our patients understand. But yes, we do have those kind of patients who are not able to make up their mind. It's quite common. Then regarding the cosmetic, with this surgery, I don't think there's going to be any cosmetic poor outcome, because the incision is going to be in the neck, and the tongue lesion has to be excised transoral, or so there is no cosmetic outcome as such, poor outcome.
Thank you, Dr. Anshika. So the next question was, some patients have more faith in their relatives and neighbors than doctors. How to overcome this type of patients? What do you do usually?
So there is, for this, I think good ear, good listening should be done. You should hear them out. Why they have faith in that relative or that neighbor which told them that you should not do a biopsy or you should not do the surgery, because there is a sensible reason. Nobody wants to not get treated, right? They want treatment. So we should understand what is their exact reason which they believe. Unless you hear them, you listen to them, there is nothing you can discuss. So I usually listen to them, that why exactly they believe, what is the correct reason. And to a certain extent, you can explain the medical science. And sometimes, sir, actually our senior, what he's doing, he has kept videos of all his treated patients, which come after 15 years or 20 years. And he shows them those videos. See, this patient I operated so many or treated so many years back with cancer, and they are still coming here. So that is one thing he's doing.
So Dr. Pankaj was speaking about support groups, which will be helpful for the patients. So to see the patients who are operated, and to talk to them, and what they have gone through. So that will also alleviate many of the fears, and that will encourage the patients to undergo surgery. So I think another thing would be, uh, there will be some relative or somebody who can influence the patient, so that it's our duty to identify that relative or the person and talk to him regarding the importance of treatment. so that he can influence the patient. That's what another thing I think that can be done in this situation. So the next one was when the patient was diagnosed, if she was not aware of the outcome of the surgery, she might be undergone surgery and may be cured. So is it true that some outcome of treatment should be discussed with relatives only and not with the patient? So this is an ethical problem.
What is our oncologist view on this thing? What do you think?
Yeah, Dr. Gaurav.
Yeah. Yeah. I think this means this sort of a case would be a sort of a good example of collusion, where I think the patient, surgeon, or the doctor himself should take the advantage. And here we saw the relatives are convinced. So it's okay, I think, to conceal some of the facts regarding the possible disfigurement or possible side effects of the treatment or the surgery. Take the patient's family into confidence, take the patient partially into confidence, so that she at least agrees or he or she agrees for the treatment. And thereon, I think this is going to be a very long task, and each and every stage you have to gradually try gaining the patient's confidence and try and help them understand what is happening and whatever effects or side effects of the treatment are there, and gradually trying to make them accept. And if the case is such the patient is incalcitrant and absolutely will not go ahead with the radical treatment, I think what doctor already said, that very early on we should make them a very familiar face with the palliative care department, so that we can start off very early, not when 9 months down the line when she's already fungating and bleeding and severe pain. So that the team with the palliation, they have a much longer timeline, so that they can manage and counsel her and treat her and help her live a more fruitful and better quality of life. So these are two important things. And I think that one more thing what could also have been done is, like, you present all the facts as they are to the patient and convince the family that once, if the family, like in this case, were sort of convinced, and then I think we can give them some time, because these are not decisions regarding, okay, should we select this thing to buy or that thing to buy. This is something which is going to change the life of the patient. So I think we can let them, okay, you come back and meet with us after a week's time. A week's time is fine, even if you're going to do a radical surgery. So let them go back, discuss at home, give them that time to imbibe the actual diagnosis, the treatment, the big surgery which is being planned. And once this sets in, possibly the family can discuss and get back to us again back in 5 or 6 days or a week's time, and we again take a shot. It's not like absolute one surgery. Oh, do you want a surgery? Okay, sign this paper and we'll post you for surgery. So I think we have to be a bit patient with the patients, and absolutely listening to what they have to say is absolutely essential. So communication, again, there it's got a huge role to play. So collusion, communication, both, and giving the patient some time to think over, to realize what is actually going to happen, rather than just hopping from doctor to doctor and hospital to hospital. So I think that is very much essential. I think we need to take the family into confidence before actually trying to convince the patient.
Okay. Pankaj, what's your take on this? Do we disclose only partial information to the patient, or what should we do here?
So in our scenario, what's the common is this collusion is a major issue. Many a times patient doesn't know the diagnosis, and they get operated and so on. So collusion is a big issue. Ideally, ethical way, we should tell the patient about each and everything. But practically, what we found useful is ask the patients how much they wants to know, what information they actually wants to know. Maybe they don't want exact survival rates, or they don't want the exact what type of surgeries we are going to do. So asking them helps a lot, and we can give the information in more sensitive way, and more in the clear ways. Like sometimes they cannot digest the informations, what they cannot understand what informations we although we think that we are talking in layman language, but for them those figures, those rates, survival rates or prognosis chances, they are not finds it easy to understand. So talking in there, so asking first what they wants to know exactly, especially in those elderly people, do they want to know the diagnosis, or what extent they want to speak. We usually speak to the patient's party first, and we try to assess how much decision-making capacity they have. Is usually in other decisions how much decision-making capacity is there, and who is the primary decision maker for them. That might help. But it's the collusion is always a difficult topic for all in our scenarios. Yeah.
Okay. So, what we can do in this, if we have to come across such patients, we can have a meeting with the support group of patients who already had the disease, and have an interaction with them, so that many of the doubts can be cleared, and so that they will be encouraged to undergo the uh, treatment. And another thing would be integration of early palliative care into cancer care, so that many things can be discussed early, and patient, even before patient is undergoing treatment, uh, patient will have many doubts and anxieties regarding treatment and disease, which can be discussed in detail. So that will also encourage the patient to undergo treatment. And finding out a person who can influence the patient and talk to the that relative regarding the importance of surgery will also help the patient to undergo the proposed treatment. And we all understand that pollution is an important problem, especially in chronic illness. So we have to work with the family, and uh, then with the patient, and the information should be tailored to the patient needs. So in this patient also, we should ask them how much she wants to know, and then go accordingly, and uh, that will encourage the patient to undergo treatment. So communication is one of the key issue which we have to use here to overcome these difficulties. So I think, Pankaj, do you have anything else to speak, or shall we close the session?
Yeah, I think that was a fruitful discussion. I hope by the discussions we had some of the queries, or maybe for the better patients management we can think of.
Okay, so thank you, Pankaj, for joining us today, and for the session, for having a wonderful session. Thank you, all the others who has joined today, and we will see you on next Wednesday. Thank you.
Thank you so much. Thank you, one and all. Yeah.
Thank you, Doctor. So I have given the feedback form. Please do log in and give your feedback. So we will see you on next Wednesday. A topic on wound management taken by Shiba.